2. So it breaks down. At the end of these, what happens is, this is your alveoli, so these are little pockets of air, and the blood vessels run right next to it. And the way you actually oxygenate your blood cells is they pass by in capillary formation, and there's a lot of oxygen here, and it diffuses across. So, so that's how you oxygenate. Now, if these suddenly become inflamed, think about this. So this disease can inflame. This is any disease. So ARDS, this all becomes inflamed, number one. So when this is all inflamed, how easy do you think it is to get oxygen across something that's thick and squishy versus something that's thin and porous?
Okay.
So number one, you can't get oxygen that way. Number two is that you also, when you get any disease, any sick enough, your blood vessels become leaky. So you get that kind of puffy, you vasodilate because you have a fever, and that's the way to cool yourself down. So blood, and then you also are sending cells, so you're sending macrophages, all this out into the bloodstream. So in order to do that, you actually, your body can say, hey, open up these little pores, and so this will sneak out. Well, the problem is if these start getting out, that also becomes, and you get wetter lungs. That's where your wet lungs. So now you have lungs that are, the tissue, these are now, there's water on the outside, or that they're a little bit not quite able right here, that tissue is also more filled with fluid. So between those two, of course. So the way, what?
No, go ahead.
So between those two, that's how it becomes very difficult. Now, of course, months ago, our first hypothesis was, well, maybe you're getting a superimposing pneumonia because that's what happens in influenza typically. But in this case, we're saying no, the disease itself is causing all this, which it can. Again, anything, you know, you can get a transfusion and get ARDS. I mean, ARDS is not due to one thing. It's just a constellation of symptoms right there. So that's what happens, and then, so that's where you get hypoxic. So the thought behind PEEP, and again, we haven't done this for years, so everyone when they go on a vent gets PEEP 5. That's just what your diaphragm would normally pull. So our thought used to be years ago, is I got this tube in here, I'm getting 100% oxygen, so I can't go. There's not 150% oxygen, there's 100%. And it's still not crossing, getting into the bloodstream. So our thought used to be, well, what if I add a little more pressure, which made sense years ago. What if I add a little more pressure, turn that PEEP up to 8? In my years, I've gone as high as 20 to keep people alive. But again, 100%, I don't have a lot more options. So PEEP at 8. Well, what they ended up finding over the years is, well, once I start cranking that dial up, 8, 10, 15, what can happen is you can actually just get injury, barotrauma. So think about barotrauma. So now you're getting high pressure on these surfaces. Well, is that causing some swelling too? Because they're getting a repetitive higher pressure. So 7, 8, I don't know how many years ago now, we said, oh, maybe we shouldn't do that. Let's try and keep the PEEP at 5. But actually, basically, turn up the rate. So you turn up the rate, so you're getting more oxygen in here in frequent breaths.
Okay, faster. Yeah.
Faster, but you have to give them proper exhalation time. So you got to avoid stacking, or you just hyperinflate the chest.
Turn the capnography or the CO2 up?
Well, yeah, so you have, no, you don't want to turn it. So what you do is, hey, have it on, and you're looking for that number. If that number's creeping up, you actually have to turn down and let it longer. So you typically have a quick inspiration, and you have a longer exhalation time. So you get more time to breathe off the CO2.
Okay.
So you can adjust all of that on a vent. But what we also did for ARDS years ago is something called Flolan. So we started using something called Flolan, which, and we've also used nitric oxide in the past, which actually tries to dilate these blood vessels a little bit, not make them leaky. Actually works to basically perform a better, I won't explain all of Flolan, but Flolan had some success where I had to worry less about turning up this PEEP anymore.
Okay.
But it's, again, if I've got this on board, and this on board, and this on board, and I do a blood gas, and their PO2 is still only sitting at 40, what's my last option? We have one more option, which we've used for years, and which we used before we had Flolan, which if you see a patient prone, I usually say, well, you might as well tell the family that they're probably still going to die, is you turn them on their face.
Yeah.
And that's proning. But now remember, you have to have a patient then flat on their face in bed with a tube hanging out. So you know how many times that thing becomes dislodged? And you know how long you have to flip them back? You can do CPR from behind, you can shock from behind, it's just less effective. So basically, you eventually try and, but yeah, because they're gonna likely pass in this, and so if they're still a full code, you now have to flip the patient.
Jeez.
But you prone them and try and, because it's more dependent anterior area, and you have actually longer lungs in the back. Your lungs actually, that's why you do a side chest x-ray. So your lungs go like this. This is your back. This is your front. So at the end of the day, we prone patients, but then their face becomes swollen, everything else, because all that fluid that normally settles in your butt, everything settles anteriorly. So, like I said, we prone patients and can do that. That's why patients that who aren't intubated yet, we say, yeah, lay on your stomach if that feels better, if you feel like you can get more oxygen, if you're not intubated. That doesn't hurt anyone if they feel short of breath to try and lay forward. A lot of people say they feel then, though, claustrophobic because, again, there's no comfortable position to lie with your head unless you have a head cutout.
Right. Good stuff, lady.
So that's why I say, of course, we haven't turned up the PO years, but when you're telling me I've done all of this and the patient still only got a PO2 of 40, I tell the family either we quit here or we try this and maybe I make it worse, but maybe I make
At
it
40, are they getting brain damage?
better. Probably. I tell families.
Right,
It's
well,
not possible to tell because by now I've already paralyzed them.
You turned it off on me at that point. I don't want brain damage.
Right, but I mean, think about it, to make a respiratory rate of 30 some, what happens is patients start bucking the vent because your brain isn't telling you to breathe 30 times a minute, 28,
So
30
they're
times
like
a minute.
pushing back again.
So you got to paralyze. So by now they're paralyzed, and I'm never going to paralyze someone and keep them awake.
Yeah.
That's cruelty. So you always sedate them and then paralyze. So again, I don't know how these patients feel, but I don't know if they have brain damage because I'm never going to wake someone up and unparalyze them because again, to breathe 28 to 30 times a minute, nobody wants to let that, or they breathe desynchronously, even if they want to breathe that quick. Because say I put a tube down because they're already breathing 24 or 28 times a minute.
Mm-hmm.
At the same point, do you think they're going to breathe in sync with the vent? No, nobody's going to comply with that. So again, you're paralyzed if you have AODS. So that's why I say that hasn't been our first thing ever. That's why I say when I do that, it's not because I don't know better. It's because all of this has been exhausted and I'm trying to push it one last.
Okay. Thank you.
So
There you have it.
that's for your
Med school.
entertainment only.
Well, it's not entertainment. You may need
Yes.
it for your family members.
So,
Thank you, dear.
but